Welcome, everybody. I hope everyone's week is off to a good start as we're getting here towards the end of the academic year. So our final presentation for this academic year is a really interesting one. Chak did this for us last year and was a really great talk. So I'm really excited that he agreed to come back and do it again for us. So Chak or Dr. Chakrati Inampudi is an assistant professor of cardiology at the Medical University of South Carolina, and he's graciously offered to talk to us today about cardiopulmonary exercise testing and the evaluation of patients with pulmonary hypertension. So Chak, thank you again so much, and really excited to see your presentation.
Thank you. Thanks for having me. And thank you all for taking the time to join today. Again, as mentioned, I'm one of the heart failure faculty at Medical University of South Carolina and the medical director of the Cardiopulmonary Exercise Lab. I have no relevant disclosures to this talk, but all I can say is I'm not an expert, still continue to learn like each one of you every day. So we'll have a couple of pretest questions. First, it's going to be a 60-year male with history of non-ischemic cardiomyopathy who's undergoing cardiopulmonary exercise stress test. Questions, which of the following parameters, when numerically high, indicate the presence of pulmonary hypertension? There's some of the options listed here. And we'll go through the data and then discuss the questions again at the end. The other one is a 36-year-old male with history of pulmonary arterial hypertension, also undergoes a cardiopulmonary exercise stress test. And in this situation, which of the following parameters indicate when low indicates poor prognosis? Today, we're going to, so from an objective standpoint, we'll review indications of cardiopulmonary exercise stress test. We'll define some of the key variables that are measured. We'll review the hemodynamic definition and the pathophysiological abnormalities of pulmonary hypertension, and we'll discuss the role of CPET in pulmonary hypertension. Just from a broad indication standpoint, I would say CPET is useful to evaluate functional capacity and or to quantify exercise capacity. It's very helpful in preoperative risk assessment, and I spend a lot of time doing this. As I support our abdominal transplant program, I use the CPET as a way to risk assess patients prior to their non-cardiac surgery, specifically the renal transplant or or a liver transplant surgery. We can also use to prescribe an exercise program for patients. The CPET will also help us to understand or evaluate the pathophysiological mechanisms that are leading to exercise intolerance in the patients. And as a heart failure cardiology fellows and faculty, we spend a lot of time in doing transplant assessing patients for cardiac transplant and also to track the effects of therapeutic interventions or the disease prognosis progression. The benefits, as I mentioned before, to quantify the degree of exercise impairment, we can also rule in or out a pulmonary mechanical limitation to exercise. We can identify disorders that are manifested by an abnormal O2 delivery, or to identify disorders of oxygen uptake and utilization like pulmonary hypertension. Now, important to understand that the CPET is a symptom-limited exercise test. We examine the response of the cardiovascular, ventilatory, and the muscular systems. We measure the heart rate, blood pressure, and EKG response in addition to all the CPET variables. As you could see in the bottom picture here, as we exercise, where there is increase in respiratory rate and the frequency, so is also the stroke volume and the heart rate. There is increase in recruitment of the pulmonary circulation. And in response to exercise, there's also dilatation of the peripheral circulation. There is increased flow in all of these. And the cardiopulmonary exercise stress test try to integrate all the variables that are obtained to really understand the pathophysiologic mechanisms that are causing the patients to have dyspnea or any other issues. The procedure itself has a resting phase to adapt to the mask. It has an unloaded phase, an incremental exercise phase, and a recovery phase. Now, I would say for any ideal CPET report interpretation, you would want at least 10 minutes of exercise, ideally. Now, having doing this for more than 4 years and reviewing more than 400 CPETs in my last 4 years here, I would say this has been a challenge because many patients, especially with pretty severe heart failure and patients being evaluated for cardiac transplant, we might not be able to get the exercise phase to almost all the 10 to 12 minutes. But there's still some data that is helpful that was understand the limitations the patients might have and to determine if the transplant is ideal for the patients. Some of the key variables measured are oxygen consumption. We measure the maximum and the peak VO2. We measure the ventilatory equivalence, which is the VE-VO2 and the VE-VCO2. We also measure the respiratory exchange ratio, the ventilatory anaerobic or lactate threshold. We measure the exercise oscillator ventilation and the oxygen uptake efficiency slope. This is a classic 9-panel plot that is obtained from the Wasserman textbook. And important to understand that this is pretty standardized across all the institutions that perform cardiopulmonary exercise testing. In this, we spend the plot 1, plot 2, plot 3, and the plot 8. We help us to understand the cardiovascular functioning during the exercise. And with regards to plot 4, plot 7, it will help us to understand the metabolic or the gas exchange factors. A systematic approach of CPET interpretation involves understanding the cardiovascular and the metabolic responses, pulmonary gas exchange efficiency, and also the breathing mechanics. Some of the CPET variables that are classically described in heart failure is going to be taking consideration the peak VO2. We all are familiar, if not, this is something that everybody in heart failure needs to be familiar with. It's the Weber classification of how we evaluate, how we differentiate patients with heart failure and their risk. Weber class A is the peak VO2 greater than 20, and the Weber class B is peak VO2 16 to 20, class C is 10 to 15.9, and class D is severe. Important to understand, for us to interpret the peak VO2, we have to have an RER, which is a respiratory exchange ratio, greater than 1.1, indicative of excellent effort. Now, if your RER is greater than 1, that is adequate effort, but from a professional society guideline recommendation, it's greater than 1.1. And if your RER is less than 1.1, it is submaximal effort, at which time we would understand we would need to move on to the VE-VCO2 slope that help us to understand the prognosis in heart failure patients. If the slope is less than 30, then it's normal. And if it's greater than 45, it's severe. Now, moving on to hemodynamic definitions in pulmonary hypertension, we have, for the longest of the time, we used to have mean PA pressure greater than 25 as a cutoff to diagnose somebody with pulmonary hypertension. And the most recent iteration of guidelines change in 2020 has indicated the pH now is mean PAP greater than 20. And if you have a mean PAP greater than 20 with greater than 2 Wood units of PVR, and less than 15 of pulmonary capillary wedge, it's precapillary pulmonary hypertension. And if you have wedge greater than 15 with the PVR less than or equal to 2, that's left PH due to left heart disease. And combined pre and post capillary pulmonary hypertension is mean PAP greater than 20 and the PVR greater than 2. Also have a wedge greater than 15. There's also an entity called exercise pulmonary hypertension that is still ongoing, continues to be evolved. The data evolves on a yearly basis on this. And this requires a mean PAP cardiac output slope between rest and exercise of greater than 3 millimeters mercury. Now, a quick note on the clinical classification in pulmonary hypertension. We have idiopathic group, which is a group 1 pulmonary hypertension. Group 2, PH due to left heart disease, which many of us are familiar with and deal with it on a daily basis. Group 3 is PH due to lung disease. Group 4 is pulmonary hypertension associated with pulmonary artery obstruction. And Group 5 is PH with unclear or multifactorial mechanisms. In my practice, who cares for patients with pulmonary hypertension, also in addition to heart failure, I see pretty much all formats of these pulmonary hypertension. Now, in pulmonary hypertension specifically, cardiopulmonary exercise testing may be used to screen and risk stratify patients with suspected or established PH. It may elicit early and reproducible abnormalities suggestive of PH. And important to understand, it is safe to perform in an established PH patients. Some of the key variables, in addition to what we've discussed before, is as usually in maximum oxygen uptake. We review the ventilator or gas efficiency. We also take into consideration arterial O2 desaturation and the PET CO2 changes. We also review exercise oscillator ventilation and oxygen uptake efficiency slope. As you could see here, there are many variables that can be helpful in evaluation of patients with pulmonary hypertension, and CPET data is very valuable before you have to perform a right heart cath on patients. Although it's important to understand, right heart catheterization still remains a gold standard test, despite being its invasive nature for diagnosis of pulmonary hypertension. Now, some of the common pathophysiologic abnormalities in PH include patients exhibit reduced cardiac output and aerobic capacity. They have ventilatory efficiency abnormalities. There's also dynamic hyperinflation, as noted by decrease in inspiratory capacity in inspiratory reserve volume, which is more classic in COPD patients. There's also locomotor muscle dysfunction that happens when patients with PAH. Now, what causes the ventilatory inefficiency abnormalities? Because of the VQ mismatching that happens, which is widely noticeable when you exercise the patient. Larger than normal end-tidal PCO2 differences. There's also increased dead space due to reduced perfusion of the ventilated alveoli during exercise. And there is elevated chemo and muscle receptor sensitivity. There is early lactate accumulation. And there is elevated pulmonary pressures causing decreased alveolar capillary conductance. Understanding the mechanism of intolerance, exercise intolerance, PH, is very important. As you could see here, patients have pulmonary arterial obstruction in the primary pulmonary hypertension, or whether you have chronic thromboembolic PH. There is increase in the mean PA pressure, and there is decrease in pulmonary capillary bed recruitment. Then ultimately, there's, from a cardiac standpoint, there is increase in RV afterload with associated decrease in LV filling. This ultimately leads to decrease in cardiac output, and which translates into decreased peak VO2 or peak VO2 work rate ratio. There's also, because of the decreased blood flow, there is peripheral muscle dysfunction and deconditioning that happens with time. That ultimately leads to leg fatigue, which is one of the most common reasons why patients actually stop exercising. Now, when you look at from a lung standpoint, there is VQ inequalities. There's VQ mismatch that I discussed about. No, please note that there's always a VQ mismatch or at a smaller fraction in normal patients, because when you're standing based on the gravity. But this gets exaggerated in patients with pulmonary hypertension because of decreased blood flow. Now, there's also increased VD by VT, which is the dead space fraction. And there is increased PET CO2 with associated decreased PaO2. All of these lead to excessive and inefficient ventilation that ultimately leads to abnormal ventilatory mechanics in patients with PAH. Now, moving on to individual variables, there is looking at maximal oxygen uptake or peak VO2. The VO2 max decreases in established patients, even in milder forms. And important to note that it correlates inversely with resting pulmonary hemodynamics, and it may improve with pulmonary vasodilator therapy. It's a powerful predictor of mortality, and studies have shown that a peak VO2 less than 10.4 ml per kg per minute is a key criteria for early mortality in PAH. Moving on to anaerobic threshold, this is also a misnomer. Important to understand that there is no anaerobic phase that is involved. It's not the lack of blood flow. It is also called as lactate threshold or the ventilatory threshold. Here I provide you the normals, and the anaerobic threshold generally occurs at around greater than 40% of the predicted peak VO2 in normal individuals. And this is a study that actually shown that anaerobic threshold could also correlate inversely with resting pulmonary hemodynamics in patients with established pulmonary hypertension. As you could see here, the anaerobic threshold in patients who had, this is a slide that shows patients with severe primary pulmonary hypertension and patients with moderate pulmonary hypertension, and this is a patient who's got normal pulmonary hemodynamics. As you could see here, there is in patients who have severe primary pulmonary hypertension, AT occurs far earlier than from patients who have normal pulmonary hemodynamics. When looking at the VCO2 slope, this is an example that provides us an understanding. As you could see here, this slide here that documents that demonstrate the VCO2 slope normal of less than 30, as I mentioned before. And this is a patient who's got a normal VCO2 slope of 24. And different depictions of patients who had with pulmonary arterial hypertension, pulmonary veno-occlusive disease, and so chronic thromboembolic pulmonary hypertension, as you could appreciate the very steep VCO2 slope in CTEPH. Now, it's important to understand for us, for patients who've got a VCO2 slope of more than 45, in your clinical practice, when you see that situation, almost always please take into consideration of the possibility of chronic thromboembolic PH. So consider performing a VQ scan as a screening test to evaluate for chronic thromboembolic PH in that specific subset of patient population. Again, the number for VEV0 slope of greater than 45. Now, looking at the VEV0 slope in primary pulmonary hypertension, it's another example of during the exercise, and also, as you could see here, at rest and during unloading phase and during the ramp exercise phase, the VEV0 slope progressively increases with continuing exercise, indicative of the worst the ventilator inequalities that these patients experience with time. And on a different note, looking at the VO2 to work rate ratio, it's going to be less than 10 ml per minute if you have severe primary pulmonary hypertension, with normal being greater than 10 ml per minute for the changes in the VO2 to the work rate. So putting this all the data into a summary, common things in CPET is in some of the reduced variables include the peak VO2 less than 20. And just a quick recap, less than 10.4 indicates poor prognosis in PAH. And if your VO2 to work rate ratio less than 10 ml also indicates poor prognosis. And O2 desaturation during exercise greater than 3%. Generally, you don't see that during pulmonary PH due to left heart disease. And also the PET CO2 at rest at anaerobic threshold. Now, the variables that increase is the VO2 slope that we have discussed before, and also the dead space fraction, which is a VD by VT during exercise. There's an increase of greater than 30%. So a VVCO2 greater than 40 and a PET CO2 less than 30 has been shown to be highly predictive of elevated PVR with exercise, and a VVCO2 ratio at anaerobic threshold greater than 55, if you see that, identifies patients with 7-fold increased risk of death within 24 months. And the largest I've actually seen was around 65 for one of the patient. Now, moving on to pulmonary hypertension due to left heart disease. This is a classic work by Dr. Gwazi and group. It's a retrospective study of 263 patients with heart failure. Their age was 63 plus or minus 10 years. And the LVF was around 36 plus or minus 11%. Here they did an upright graded exercise test using a cycle ergometer. Here at MUSC, we perform most of our testing with treadmill. And as you could see here, the study indicates that if your VVCO2 slope of greater than 30 equal or greater than 36 is best predictor of the PA systolic pressure of greater than or equal to 40 millimeters of mercury. This is something that I keep observing on regular basis when I do the right heart cath for patients, and also when we read this cardiopulmonary exercise testing at the same time. Now, please note that a PET CO2 threshold of less than or equal to 34 has also been shown to have a good ROC for detecting pulmonary hypertension in the patients. In this situation, in this study, they have actually they noted that the ventilated class, the AUCs are around 0.82 and highly statistically significant. Now, looking at differences in PA systolic pressure according to various parameters, as you could see here, for patients with PET CO2 less than 34 and PET CO2 greater than 34, the PA systolic pressure is more than 40 for these patients when compared to when the PET CO2 is less than 34, it has normal PA pressures. Now, pulmonary hypertension with left heart disease, also, we can estimate the slope versus a PA mean and the PVR also. This is a study that looked at 57 heart failure patients. And the study has shown that if you have pulmonary hypertension, with increasing NYHA functional class, the VVCO2 slope also increases, so is the PA mean pressure. And looking at from a PET CO2 and VVCO2 slope standpoint, this is a study of 39 heart failure patients, of which 11 had no pulmonary hypertension, 12 patients had left heart disease, pulmonary hypertension, and 16 had combined pre- and post-capillary pulmonary hypertension. And as you could see here, for patients who have heart failure and pulmonary hypertension, their mean PA pressures are elevated and it's more than 40. And looking at VVCO2 slope and PET CO2 in PH on a different format, looking at their PET CO2 levels, as you could see here, their PET CO2 levels decreases with increasing pulmonary pressures. Now, moving on to other variable called exercise oscillatory ventilation, which is here we provide you the mechanistic basis for the development of ventilator instability for these patients. In patients with heart failure, with increasing heart failure severity, there is increase in LV pressures, leads ultimately leading to pulmonary congestion that leads to RV dysfunction. And the increased pulmonary congestion leads to stimulation of juxtacapillary receptors, that is increase in ventilatory drive, that ultimately leads to increase in rate of depth of increase in rate and depth of breathing, and subsequent increase in VD by DT. Similarly, the reduced cardiac output leads to circulatory delay and stimulation of the peripheral chemoreceptors in the carotid body that stimulates the PaCO2. There's a decrease in PaCO2, ultimately all of this translating to development of exercise oscillatory ventilation in patients. Now, specifically, when we look at from a pulmonary hypertension standpoint, as you can see in a single center retrospective study of 131 patients, and hemodynamics were obtained in 61 patients with reactive PH. If they have high VCO2 slope and delta, if the end tidal CO2 is greater than 32 and exercise oscillatory ventilation is absent, then PH can be safely excluded. But if you have exercise oscillatory ventilation, it's a frequent finding in patients with post-capillary pulmonary hypertension. Moving on to oxygen uptake efficiency slope. It's a non-linear measure of ventilatory response to exercise. It describes the relationship between minute ventilation and the VO2 during an incremental exercise, and it takes into consideration the logarithmic transformation of ventilation. It is defined as a regression slope of A in VO2. And important to understand for patients with PH, the low oxygen uptake efficiency slope predicts worse outcome in PH patients. And they actually, if from a numbers perspective, if you want the cutoff, it's 0.56 for liters per minute in this single center study of 98 patients with pulmonary arterial hypertension. Now, moving on to understanding the role of CPAT in CTEPH and also chronic thromboembolic exercise, chronic thromboembolic disease. It does have a diagnostic and the potential prognostic value at 3 months following the PE. It helps to diagnose prevalent ventilatory insufficiency following PE, and to evaluate for persistent PH following PTE, and to differentiate post-PTE patients who may derive benefit from pulmonary vasodilator therapy. And important to understand that a VCO2 slope of greater than 60 revealed a very high risk of death at 2 years for this patient population. Now, in this prospective study that was conducted in one of the center, taking into consideration, taking 396 patients who have had at least one CPAT test done, 363 patients had CPAT at 3 months. Of them, 268 also had repeat CPAT at 12 months. Now, it's important to understand 90% of the patients have had ventilatory inefficiency following an episode of pulmonary embolism, and 30% of them had insufficient cardiopulmonary limitations. Now, these patients, when you perform cardiopulmonary exercise test, when your slope is high early on following the diagnosis, and if they have developed chronic thromboembolic pulmonary hypertension, if they're amenable to surgery, which is the standard of care for patients with CTEPH, and you're able to complete the surgery, many patients actually have resolution of the ventilatory abnormalities following the pulmonary thromboendarterectomy. But there are minor fraction of patients who have had either a distal disease or a small vessel microvasculopathy. They might still have some residual pulmonary hypertension, as noted by elevated VCO2 slope and with residual ventilatory abnormalities. These patients may benefit from pulmonary vasodilator therapy, or some centers who have an expertise in performing balloon pulmonary angioplasty that can also be helpful. And you can actually repeat CPATs in these patients to understand the benefit of the drug therapy. Now, just a quick note, the vasodilator therapy that is commonly used for these patients is the riociguat for patients with chronic thromboembolic pulmonary hypertension. If they're not candidates, that's also another treatment, same treatment, the riociguat is used. Now, differentiating pulmonary hypertension causes using cardiopulmonary exercise testing. PH patients have higher VD by VT and VCO2 slope that we've discussed before, and we've provided a few examples. And they also have a lower PET-CO2 and O2 pulse. Important to note that a VCO2 slope of greater than 40 and a PET-CO2 less than 30 have been shown to be highly predictive of elevated PVR with exercise. And PAH patients classically exhibit hypoxemia during exercise, which you don't see in PH due to left heart disease. However, exercise oscillatory ventilation is very common in patients with heart failure and who have coexisting pulmonary hypertension due to left heart disease. due to stimulation of the pulmonary J receptors from the high LV filling pressures. And we just reviewed the mechanism of the EOV in the previous slides. Now, this is a slide that puts together all the CPAT abnormalities in patients with pulmonary vascular disease. Now, you could see here in the PAH world, you could see the decrease in peak VO2. And again, the number is less than 10.4. And VO2 at 80, the VO2 workular ratio being less than 10 ml per minute. And the O2 pulse is also decreased in PAH patients. Their slope is elevated, and very high slopes, we need to check for coexisting chronic thromboembolic pH. And very high slopes greater than 55 is indicative of poor prognosis in patients with pulmonary hypertension. And when it comes to looking at CPAT parameters and the mortality perspective, we've previously talked about this, which is if your peak VO2 is less than 10.4, with a high specificity of 69%, there is a high risk of mortality 1.88. But if your slope VVCO2 of greater than 55, as you could see here, the odds ratio is almost 15, and indicating a very poor prognosis too. And if it's more than 60, it's also quite bad. This is a study that looked at 116 patients, and PAH included both PAH and the CTEPH patients on drug therapy. Now, assessing the efficacy of therapeutic interventions. If your peak VO2 is greater than 15 and VVCO2 slope of less than 36, they found the low risk of patients in the pulmonary arterial hypertension. And ideally, these are the goals that you would want to establish for patients who've been started on PAH-specific therapy. Now, important to understand the IV prostacyclin, which has been shown to reduce mortality in patients with advanced pulmonary hypertension. The use of IV prostacyclin has been shown to improve peak VO2 by almost 36% in some patients. The improvement in peak VO2 and the O2 pulse are related to improvement in the RV function. As we reviewed before, the patients who have pulmonary arterial hypertension, the increased mean PA pressure, and the pulmonary arterial obstruction leading to decreased pulmonary capillary bed recruitment. This leads to increased afterload during exercise, and the increased afterload leads to decrease in peak VO2 on the cardiac output. In CTEPH patients following PTE, there's also improvement in the peak VO2 and decrease in the ratio. And in a meta-analysis of 416 participants, exercise training has also shown to be beneficial in patients with pulmonary hypertension, with improvement in peak VO2 by about 1.84 ml per kg per minute. From a medication standpoint, this is one of the studies that looked at benefit of sildenafil in patients with pulmonary hypertension due to left heart disease. This study has shown that as the PA pressures decrease from a baseline to a 3-month mean of from 29 to 24, with a mean change of 5.2, there is also an improvement in the peak VO2 from 14.6 to 15.8. And as you could see here, the breathlessness also has decreased, and the emotional function of the fatigue has also come down. So this highlights the importance of sildenafil in reducing the PA pressures. More importantly, it will help us to understand that the cardiopulmonary exercise testing can also be used as a test to understand the prognostic changes that happen for patients. One other keynote to understand here, as more commonly, the VVCO2 slope also has decreased from 33.5 to 31.4 for patients at 3 months on sildenafil. A quick note about invasive cardiopulmonary exercise testing. It's increasingly used for early diagnosis of exercise-induced idiopathic or secondary pulmonary hypertension. A mean PAP, cardiac output relationship, greater than 3 millimeters mercury per liter per minute is reflective of pulmonary hypertension response, which is manifested also by elevated VVCO2 slope. ICPAT assists in diagnosis of HFpEF, mitochondrial myopathy, and confirmation of any deconditioning. The problem with the ICPAT is the invasive nature and the technical challenges in obtaining reliable hemodynamic tracings. Some things that I routinely do in our right heart cath lab, this has been an ongoing challenge, but hope the future iterations of the testing pattern should allow us to understand more and more on this data. Some of the invasive CPAP characteristics of pulmonary hypertension, as we've talked about, there is decreased VO2 max, there is decreased anaerobic threshold, and there is also blunted VD by VT ratio with O2 desaturations or widened AO arterial oxygen O2 saturation greater than 30. Now, looking at from a right heart cath parameter standpoint, a decrease in peak VO2 max is also corresponding to peak pulmonary artery pressure of greater than 30 millimeters mercury, a PVR of more than 120. Pulmonary capillary wedge pressure RAP ratio slope of less than 1.4, and the mean PAP cardiac output flow slope of greater than 3. Now, a role of CPAT in undifferentiated dyspnea. The CPAT findings in a patient with undifferentiated dyspnea is, you will notice that these patients experience low peak VO2, elevated VVCO2 slope, low O2 pulse, and a normal breathing reserve. Now, it's important to understand that, when you combine the gas exchange testing with exercise right heart cath in an ICPAT patient using the ICPAT, there is, for undifferentiated dyspnea, there is increase in the PVR, and the wedge still remains low. And if you have a low wedge cardiac output ratio, the diagnosis is consistent with more exercise-induced precapillary pulmonary hypertension. And these patients usually benefit from vasodilator therapy. But if the PVR decreases with exercise and the wedge increases with large V waves, obviously we are now something that is classic of HFpEF with LA myopathy. In conclusion, CPAT is a useful tool to screen and risk stratify patients with suspected and established pulmonary hypertension. And the VVCO2 slope, PET-CO2, and severity of oscillatory ventilation during exercise has been shown to be associated with reactive pH in heart failure patients. A slope greater than 40, please consider the potential for a secondary pH and more definitive diagnostic test to determine pulmonary pressures. And a slope greater than 40 and PET-CO2 less than 30 at 80 is highly predictive of elevated PVR also, in addition to the mean pulmonary pressure. And as I discussed before, CPAT can also help track disease status over time and assess effectiveness of the therapy. Now, just moving on to the quick post-test questions. And as we've reviewed the first question, the 60-year-old male with history of non-ischemic cardiomyopathy who undergoes cardiopulmonary exercise testing. And which of the following parameters, when numerically high, indicate the presence of pulmonary hypertension? As we discussed before, very high VVCO2 slopes continue to be a more important parameter in the assessment of pulmonary hypertension. And this, just a quick recap, a slope greater than 36 indicates a PA mean pressure of systolic pressure of more than 40. And in a separate patient with a 36-year-old with PAH who undergoes cardiopulmonary exercise testing, which of the following parameters, when low, indicates poor prognosis? It's going to be the low peak VO2 we discussed before, and the ratio and the level less than 10.4 indicates very poor, indicates a high risk of mortality for patients. Thank you.
All right, well, thank you so much for your talk. Any questions from the group? Yes, one question I had for you is, we don't, in our practice here, we don't tend to, I think, see CPAT as commonly or use it as commonly probably as you do at MUSC. So just within the regular clinical flow of patient care, where do you tend to, what kind of questions are you most commonly being asked, or when, are you most commonly getting people referred for CPAT as part of just normal patient care? Just trying to think about where possibly in the center where we're not using CPAT as frequently, maybe where we should start thinking about using it as a tool that could provide some additional prognostic or diagnostic data for us.
Yeah. So I would say there's three separate subset of patients, Michael. One is for all patients who are being referred for advanced cardiac therapy. Obviously, we refer CPAT as a main strategy. Now, one thing that we have changed our practice in our group here, as I continue to expand more, every patient with heart failure, we perform CPAT on a yearly basis for them.
Wow.
And part of the reason is for patients who are also listed, we do it on a yearly basis. Because many of the times, what I've noted is for patients who we start guideline-directed medical therapy, we might not see all the benefits as quickly as 3 months or 6 months. In fact, the most recent paper that was published in European Journal of Cardiology has shown that it might take even 1 year for recovery of LV function in some patients on optimal GDMT. So I tend to make sure that I perform CPET on all my heart failure patients and pulmonary hypertension patients on a yearly basis. And that is for twofold. One is a change in the peak VO2 by about 10% in either direction. If it's better, that indicates a better prognostic variable, better prognosis for patients. So they have last year, the peak VO2 was 14.7, and this year it's 16.8. Less likely this is a patient that I would want to continue to be seen in the pre-transplant clinic. But if they drop from 14.7 to 12.5, this is somebody who I probably would want to make sure that that we're continuing from an evaluation standpoint. So that's one of the common things. So I would say, have about 1,000 heart failure admissions to our health system on a yearly basis. And we tend to perform CPETs on a regular basis for all patients who are coming to our heart failure clinic, whether it's a heart failure reduced EF or for heart failure preserved EF also, because there is data now to show that a low peak VO2 in heart failure preserved EF is also indicative of RV, PA uncoupling, and also pulmonary hypertension in these patients, which we know is a poor prognostic marker in HFpEF patients also. So we tend to do CPETs on a regular basis for them. Now, our pulmonary folks who have the PAH patient population, I collaborate with them. And every time they make a change in the clinical therapies, then they try to risk stratify them in sometimes once every 6 months or sometimes every year until they cross the threshold where they are deemed to be low risk. Like the one that I proposed before, if your peak VO2 is high at more than 15, then that's an indicator of a reasonably good prognosis or low risk PAH patient. And another area that I also use, as I mentioned before, for all patients, because I manage patients going through cardiac risk stratification for abdominal transplant, I actually perform CPET compared to the standard NYHA functional class assessment that we do for patients. Peak VCO2, more importantly, the VO2 at the anaerobic threshold. The VO2 at the anaerobic threshold, less than 10.4, indicates high risk of cardiac outcomes and longer hospitalization for patients with abdominal transplant. So I do that for some patients who I commonly see who have non-ischemic cardiomyopathy that is 35 or 40 years young and have LVEF of 40, 42, or 45% or 35% in some situations. Our kidney transplant team in the past, they used to deny them for transplant. But this is somebody, when you ask a specific questionnaire, they say they're able to climb up 4 flights of stairs, 6 flights of stairs without any issues. Now, those are the patients I have put them on conducted CPET and have safely allowed them to get through the kidney transplant pipeline and get transplanted. So it's another test that corroborates the evidence that despite a low LV function, they have done, their exercise performance is really very good. So they have, by descriptive terms, their METs is more than 4, but this also adds an incremental data to us. And then some situations I've also done right heart catheterizations for these patients. And I've shown that their cardiac output is normal and their pulmonary pressures are normal. So the EF is 38% or 35%, but they have a completely normal cardiac output and they have normal pulmonary pressures. And we know in general, these are the patients who we can safely get them through an organ transplant without any issues. So I use the CPET also in that format quite a bit.
Well, if there's no questions from the rest of the audience, I want to thank you again, Chak, for taking the time today to talk to us about this really interesting and complex topic that I think a lot of us don't tend to get a chance to experience very often. And I hope everybody has a great summer. We'll reconvene in about 4 weeks and pick up the lecture series at that time. Thanks so much. Bye-bye.
Thanks, Michael. Thanks for having me over.
Bye-bye.